Awesome. Perfect. Well, for those that are new to our fireside, welcome, welcome, welcome. And before we take a deep dive, I want to have everyone close their eyes. And one of the things that we have built a tradition here at Angle Health is around this concept of a key log, right? And I want to kind of share a key component with everyone here today. So I want to take you back to a different time, to a logging town nestled deep in the forest where timber was king and the river was its highway. Every spring, thousands of logs floated downstream, guided only by the current and the strength of the crew. But among all those logs, there was one that mattered most, the key log. It was the one that, if jammed, could stop literally everything, clogging the river, stalling the town's economy, threatening everything downstream. This story always takes me back to my summers, actually, as a little boy in the north woods of Wisconsin near Hayward, where every Friday night we gathered around the campfire for what we called a key log ceremony. It was a time to share something super meaningful from the week, an accomplishment, a thank you to another camper or counselor, or just a moment of growth that stood out. Each of us would toss a small wooden log into the fire, a simple act that carried reflection, gratitude, and a connection. Those moments taught me something extremely important, that progress doesn't always come from doing more, but sometimes it comes from recognizing what really matters and freeing that key log that has been holding everything back. In our world, the business of, quite frankly, employer-sponsored health insurance, that same principle applies. When we identify and release key logs, this is how we serve our brokers, employers, members. We unlock something far more powerful, better access, better outcomes, and a smoother flow for everyone downstream. So as we sit here today, and I suspect we're going to unlock some serious key logs today, let's find the one that can be freed and get everything moving again. So I'm going to pass the key log over to Caleb Parker to introduce our featured guest today.
Thanks, David. Well, our special guest today needs a little introduction. Today, we're joined by entrepreneur, investor, founder of Cost Plus Drugs, the shark himself, Mark Cuban. Mark's working hard to disrupt the pharmaceutical industry by tackling one of its biggest challenges, transparency and fair pricing. His company's mission is important: make medications affordable by cutting out middlemen and passing savings directly to patients. Mark, we really appreciate you joining us today around the fire, discuss how we can cut through the noise and start building a system where fair pricing is the foundation of care.
I
With
open
that,
my eyes.
yeah, open them up. Open them up.
Yes.
You feel the fire?
Yeah, it's everywhere. I'm
Good.
right in the middle of the river. I'm still processing the key log.
Perfect. Well, David's great at painting our picture of the fire we're all sitting around. So with that said, we'll dive right in, Mark, and really, ultimately want to start about how you got into healthcare, right? You've built businesses across industries from tech to sports to entertainment. You've always had an eye for disruption. And healthcare is a space that many people shy away from because of its complexity, but nonetheless, you've chosen to dive headfirst in. So help us understand what led you ultimately to enter healthcare and launch Cost Plus.
I got a cold email from my co-founder, Dr. Alex Oshmayansky. He reached out to me to invest in opening up a compounding pharmacy that would make sterile injectables for injectables that were in short supply, on shortage lists. I was like, that's an interesting idea, but that's not big enough. And it was right around the time the farmer bro was going to jail. And I was like, how did it happen that this guy could jack up the price of this generic drug, Daraprim, for him, 750%, 75, whatever it was? It made no sense to me. And so I started digging in and realized this industry was as opaque as it could possibly be. And that was a feature, not a bug, to most of the participants. And to me, that just created an opportunity. So we started costplusdrugs.com, and the whole underpinning of it was trust. When you talk to anybody, hopefully they trust their doctors, but they really don't trust the economic side of any part of the healthcare industry. And so we knew that we had to be completely transparent. We knew that we couldn't be greedy. We had to price not to market, but to an amount that people would feel was safe and fair. And so we decided to show our cost. show our markup of 15%, and starting with mail order, just charge $5 for shipping and $5 for the pharmacy review. And in doing so, particularly for specialty generics, we just changed the industry in terms of the price of what we sell. And that was January 19th of 2022 that we launched.
It's interesting, when I think about, the cost of care and just explaining stuff in the healthcare market, right? You follow the money and it all starts to make a whole lot of sense. So, working in this space, on the pharmacy side, I mean, it's crystal clear. And when you follow the money, obviously you can be very transparent or you can be super opaque, right?
Yep, for sure.
Yeah.
Yeah, and like I said, that's the goal of PBMs and the insurance carriers that own them. They want to have a different price for every customer. They want to be able to charge full list price, full whack to patients when that are in their deductible phase, or use copay accumulators or maximizers and take a chunk of that and put it right in their pocket. They benefit from your sickest employees generating enough utilization to create more rebates. And that's, just the beginning of where the industry is upside down.
And I think, Mark, we've talked in the past about formularies. I'd love for you to give your glowing review of formularies and where they fit in this space.
I mean, formularies are just a way for the biggest PBMs to create leverage for themselves. Effectively, they say they negotiate the best prices for the sponsors they work for, but in reality, other than generics, they don't, for brand medications, they don't negotiate prices at all. All they do is auction off access to their formularies. And as long as they have control of formularies, they have that leverage. If legislatively or just through educating states and for their employee programs and large employers, to do their own formularies, that you begin to diminish their leverage, which would be a big step towards going towards net pricing, which would save patients and sponsors a fortune.
As you were getting the whole cost plus model built, I suspect you probably ran into some challenges along the way because it's so disruptive. I mean, what might have those been?
The biggest challenge we have is a lot of the brand manufacturers will not sell through us. And the reason they won't sell to us, and we hear it all the time, even though they won't put it in writing, is that if they sell through us, they have been told that the biggest PBMs would diminish their placement on formularies across their portfolios, which could cost them tens, hundreds, or billions of dollars. So as much as they like the idea that we're being disruptive, they don't like it that much, to give up all that. And I can't blame them. But that's our biggest hurdle, because they know that, if let's just use Eliquis as the hypothetical example, these aren't the actual numbers. But Eliquis has a whack of about $600. With rebates and fees, it's closer to, well, let's just use 300 for easy numbers, right? So with that in mind, if we were to buy at $310, right, or $320 and mark it up at 15%, right? At $310, that's what, $46.50, and we're selling it for $355.50. That's a whole lot cheaper than anybody's able to buy right now when they're in their deductible phase, or that any sponsor pays when they're charged by their PBM. That's exactly what happened with specialty generics. Drugs like imatinib, where the sponsor might be charged thousands of dollars, or somebody without insurance or that's in the deductible phase could be charged hundreds or thousands as well. That's a lot of margin we took from the big PBMs. And so they didn't want to see the same thing happening, because the rebates and their ability through their rebate GPOs, through direct rebates, through spread pricing, we would undermine all of that. The smartest thing that we did, and it was unintentional, was we published a full price list. By publishing a price list of everything with our cost and our markup, that allowed companies to start comparing as best they could net prices they were getting after rebate, or for generic straight up, to what we sold it for. And that made a lot of companies mad. I was on a Senate panel with Dr. Molds, who's head of CalPERS. And he said, under oath that they used our price list to negotiate better prices from their PBM.
It sounds like, the this industry continues to thrive with keeping things in the dark, right? And as we start to expose those prices or whatever, I mean, you go to the doctor, you don't even know what you're going to pay. You go to the pharmacy. I mean, went to Whole Foods, last night, and all the prices were very clear there, right?
Right?
You go to CVS or Walgreens or
You have
wherever,
no idea.
no
Yeah, when you
clue
when you
what's.
get a prescription from the doctor, they don't say this is how much it's going to cost. They just say, what pharmacy do you use? That's it. And when the patient asks how much, hopefully they'll use our price list as a reference or get to us, and that's what's happened a lot. But you're right, and that's intentional because they price to what they're able to charge, and that depends on the customer. Do you have employer insurance? Do you have government insurance? Do you have union insurance? Are you uninsured? Are you high deductible? Are you Medicare Advantage? Are you Part D? Your price is going to be different every single time.
Yeah, not only that too, right? When we talk about formulary, we also talk about, democratization of access, right? So it's one thing of here's the drugs you can get. Now there's also the here's where you can get them, right? And Cost Plus isn't a quote unquote in network for many different PBMs, right? And I
No,
mean,
we don't work with the big three, and even some of the big six, if you will, that we work with some. We're only if we, biosimilars primarily because our pricing in biosimilars is really, really low. Um, but that's one of my tests when I talk to CEOs in particular. I'll say if you want to know if your PBM is truly providing you the lowest price, particularly on generics, just add them to add costplusdrugs.com to your network. They'll say no. And when they say no, that tells you all you need to know about their pricing. Because if they, because they're much bigger, that I mean they're multi-hundred-billion-dollar companies, so they're far, far bigger, and they probably can buy for less. But they're not passing that along, and that's the difference.
It's funny you kind of mentioned CEOs and whatnot. And, last time I checked, what do we have? Maybe 330 million people in this country, give or take, and perhaps maybe about 130 million-ish that get their health insurance from their employer.
Yeah, if
So
it's public, including public employers, it's about 170 million.
So I recently saw a LinkedIn post that you did, and
Uh-huh.
I enjoyed reading that. You called out a couple individuals,
Yep.
um, and I mean, look,
And I
employers are
heard from them. I actually talked to them.
they're employers certainly have they're tastemakers, right? I mean,
Well, it's
so
not. It's not just that. It's just you can't expect a CEO. They have their own core competencies. You can't expect a core competency of theirs to be their healthcare benefits. That's down the totem pole, and they have to do their best to hope that there aren't politics between them and the person putting together the RFP and making the decision when it comes across their desk to sign. And now they're starting to recognize, particularly with all the discussion of premiums going up, whether you're an ACA plan holder or a corporate sponsor, they're recognizing that their largest expense item after payroll is their healthcare benefits. Like Warren Buffett said, was it GM? He said is a health insurance company masquerading as a car company. And it's the same thing for every medium to large size company. The price that even for me that we paid up until recently, it was $30,000 a year for a family of five, and it's only going up. And the quality of care is there, but it's becoming, for specialty stuff, even more expensive. And so trying to work through all that stuff and help these employers is a big part of what we do.
yeah, the pharmacy piece continues to drive a huge part of that, right? Whether it's the high
Yeah,
cost
but it's all
specialty.
it's yeah, but it's all tied into the healthcare side as well, the medical side as well. And all of it starts with health insurance. All because that's the starting point for everything downstream, including the PBM. And for all of us who get employer-based insurance, your employer makes decisions on what plans to offer, and then you make a decision on what plan to choose. You know, and you typically make a determination based off of your family health, your age, your expectations. If you're younger, you pick lower premium, higher deductible, older family, vice versa. But the one thing about those deductibles, they're going up, right? An ACA plan, silver plan, is going to have a $5,000 deductible, 21,000 out of pocket. And your typical corporate plan is going from 1,500 past 2,500. And nobody asks any of those employees, can they afford their deductible? Because if you can't afford your deductible, you don't have insurance. And not only that, you put the provider, particularly the hospitals, in a position where they become subprime lenders because they want that patient plan holder to get care, and they'll lend them money or use a third party to lend them money so that they can get into past the deductible phase so they can try to collect money from insurance. And all these things cascade down so that forces the hospital to increase their prices, invent things like facility fees, play around with 340B and abuse that to get to get funding. And so all these things all go back to the insurance company, the plans that you choose, and all the intercompany transfers they do to try to game that and arbitrage it.
It's interesting you bring up, and I like to call it fundamentally uninsured, right? That person that's on a $6,000 high deductible plan that, has $65 in their bank account. And I oftentimes, when I'm on calls or presentations, I say, hey, look, I just bought you a private jet, right? A G10. And right.
And you can't afford the fuel or the pilot
you
or
can't
anything else.
you can't fuel the thing up. I'm like, hey,
Yeah.
thanks, man, for the jet. But
Right?
it costs
Can we sell it? Yeah.
$25,000 an hour to operate. I'll
Yep.
get halfway down the runway and run out of fuel.
Yeah, you won't even get in the jet, right? Well, it's just the fees, anyways. But no, your point's well taken, and nobody has ever asked anybody who getting a higher deductible plan for a credit check. And then, the vicious cycle gets worse. It's not just the deductible. From there, you get the pre-auths, right? And the pre-auths aren't only about denying care. That's really a minimal part about it. It's about delaying care so they get the time value of money. And then on the other side of the pre-authorization, there's a committee run by a 97-year-old veterinarian who's making the determination about whether or not, the care should be authorized. And that wastes hours and hours and hours of time on the part of doctors and everybody around them at the hospital. And then not only that, you get to see the prices that are negotiated with each insurer on the hospital websites. And these huge insurance companies, the biggest companies in the country, can't negotiate a better price than John Doe or Joe Schmo walking in with a credit card for a cash price. And not only that, whatever price they negotiate, let's just say it's $25,000 for a hip replacement, they're not paying them the full 25 grand. They're paying them 15 to 20 grand, underpaying them and saying to the provider, the hospital, look, sue me. So now the hospital has got to have, X number of administrative people to deal with the plans, to deal with the transactions, to deal with the paperwork, to deal with the legal aspects of being underpaid. But wait, there's more, right? They now they have to invent things to compensate for the revenue they lost through underpayment, pre-auth, expenses associated with that, and being the bad guy when people can't afford their deductibles, giving them credit, right? Being the subprime lender, and then when they have to write it off, creating medical debt to the tune of hundreds of billions of dollars across the country. So and so the hospitals now in turn have to invent things like facilities fees, which is the dumbest shit ever. Or, they do roll-ups with PE, which allows them to, to arbitrage locations. So, you buy that physician's practice, and now because you own it, your Medicaid rates are 3 times higher. You get to charge 3 times more. I mean, this whole vicious cycle starts and stops with the relationship that sponsors have with either their insurance companies, who rarely take the risk for companies, right? Whether it's public or private, it's typically self-insured, or the relationship that they should have with the provider, which should be direct, or would be even better if all these providers and independent physicians could create their own network. Because where the formulary is the leverage that the PBMs have, the network is the leverage that the insurance companies have. So that for my company or your company or Caleb's company, you can't just say, okay, I want to have a direct contracting network where I know it's all cash-based pricing, sign me up. And that's one of the pieces that if we're able to put together that with costpluswellness.com, then that'll be the game changer on the healthcare side.
It makes a lot of sense. And there's obviously some movements out there. For example, the Free Market Medical Association and other pieces of the puzzle where, there's some structure. It's just not, growing, in my opinion, fast enough.
Yeah, and there's lots of ASCs, there's lots of cash pays, right? There's lots of DPCs, that you'll just pay $60, $80 a month. And those are all great, but you can't just go one place to sign up for them. There's
No.
not one standardized contract you can use as an employer. That's the holy grail. That's the opportunity. Because, whether it's us or whoever who's able to aggregate all of them and say, this is all part of one network, and here's the transparent prices. And just like any other network, maybe there's some variance from location to location, specialty to specialty, right? That'll be okay because now all of a sudden, particularly if you're a self-insured, you just need a TPA or somebody, externally or internally that can do those functions for you. And you no longer need to waste money on premiums because the insurance companies aren't taking risks for self-insured employers.
Well, hurry up and get going on that because
We're working on it.
it's
Yeah.
every day I see these physicians throw their hands up in the air
And
and they're
quit.
like,
Yeah.
"Ugh, I can't do it." They sell their practice to a major healthcare center. They make 250, 300,000 bucks a year. They sign their life away that they're going to refer those
Everything.
people into the healthcare system where they make ridiculous dollars on x-rays and MRIs, commodity type things. And it's sad. I mean, they've basically killed primary care, right? Um,
Right. Yeah. And I mean, there's a little bit of a resurgence, but because people realize that that's the better way now. But you're right, right? It is just so back ass half words. And all it takes is creating a network. Just like for Cost Plus, all it took was, being fair and just marking up 15% and publishing our price list. If, anybody listening out there, go to costpluswellness.com, sign up, right? We have 9,000 plus providers in a network we've created. It's only a soft launch. It hasn't really truly launched yet because we still want to, expand geographically. But that's the mission. And at some point, we'll standardize because part of that also isn't just signing up. You can see all the contracts that we've signed, and they aren't necessarily the best price a la cost plus drugs, but it's a price and it's non-exclusive. So if there's 3 providers, you get to choose. And if you're a self-insured employer, public or private, it's a really good idea to assign somebody to be the healthcare CEO, if you will. Because if you can schedule it, you can negotiate it. And if you can negotiate it, you can save money. Even if it means sending somebody to the Cayman Islands for a couple of days.
for sure, for sure. It's interesting. Um, it's a complex system, right? And you've
It's
identified,
it's actually really, really simple.
well, it
That's
could
the whole
be,
thing.
well,
It really is simple. It's just the big companies, it's just regulatory capture,
yeah,
right? And and just scale capture by being vertically integrated. But this industry is the easiest industry I've ever tried to disrupt. Because on the cost side, it's just a question of what's the price, which you're going to get to eventually, right? And the smart ones are putting it out front. How do you pay for it? Can you afford it yourself? Does your company pay for it? And who takes on the risk of those people who can't pay? And that's the uncertainty, right? Should the government get involved with taxpayers? Is that a better, thought process or approach than the ACA? I think at some level it is because it's right to the heart of care. But all of those things, not one time did we say we need more insurance companies.
agreed. Yeah, it's interesting. So if you were to identify like three things, right, that are kind of the core problems, what would that be? Maybe there's more, maybe there's less. But if
Yeah,
we
I
were to
mean, it's
say,
like the fundamental issue is there's not a network for all providers who, want a fair price. There's just no way for an employer to say, okay, I'm covered. And it's very difficult for an employer, and unless all your employees are in one town, to go and negotiate all these things. So that's number one. Number two is for individuals, with the ACA, there's all the arguments right now about the premium subsidies, and it's a hard argument because on one hand, you don't want to see people's insurance premiums, triple in some cases or, skyrocket when, they can afford their deductible and they need the value of the risk that the insurance company takes. But, just giving money to HSAs won't work. And the reason it won't work is because even when you give it to the biggest, nastiest insurance companies, and even though they game it through their vertical integration, they still are supposed to spend 85% and pay out their actuarial value for those plans, right? When you just give it taxpayer money to, those same subsidy recipients, they're not all sick, right? And some of those will just go into their retirement savings, or they'll just pay the $20 plus 20% plus tax and go have a party. I mean, that's an extreme example, but you get the point that you're not going to get the actuarial value by just sending it to HSA accounts. And so we have to start thinking about, if, like I mentioned earlier, people can't afford their deductibles, whether it's a corporate plan or an ACA plan, can we set up a scenario where the taxpayers will guarantee those amounts, and the individual plan, the beneficiaries will have to do their best to pay it back like they do now, right? Without the risk of it going on their credit reports, or, so you could do a means tested repayment plan so that if you're under 250% of federal poverty level and you don't qualify for Medicaid, you don't qualify for the ACA CSRs, right? Then you pay back 2% from your employer every month until it's paid off, or until 10 or 15 years comes, whichever is first. If you make $200,000 a year, then you pay 10% until it's paid off. And the taxpayers guarantee it and the providers get paid. And the offset to a lot of that is nobody has to pay premiums because it's the taxpayers that are taking on the risk.
Do you think that the government has a significant role in moving the needle on this, or is it going to
Yes,
be entrepreneurs and business owners that's going to move the needle? Or you need,
all the above,
yeah.
all the above, right? So when CEOs of companies, understand what they're paying for their benefits, then maybe they use a TPA. Those 170 million people that are part of self-insured public or private plans, they just have a TPA. They get reinsurance, and they shop for pricing where they can. You can schedule it. You can negotiate it, right? And when you start doing that, the leverage points for the insurance companies, all the lives they cover, and the PBMs they own, all the lives they cover that they auction off on their formula, those disappear. If those 170 million self-insured beneficiaries didn't go through insurance, just went through a TPA and went through an independent PBM, or used our price list, or direct negotiated through a GPO, all of a sudden those big insurance companies have to change the way they do business. And so, then it just comes down to, what about, people who aren't on self-insured plans. And if you went to hospitals and say, look, for independent physicians, we're going to pay you hospital Medicare rates so you don't go out of business. And for the hospitals, we'll pay you Medicare rates, but you're going to get paid just like Medicare. There's no pre-authorizations, right? It's the same as the cash price or Medicare, whichever is lower. We can do that, right? And now all of a sudden, the hospitals don't have all that associated overhead and stress that comes from the insurance companies. They're not talking about their product mix or their book of business. And if they want to, charge a premium, great. You just don't opt in to having the deductible and the amount to be paid by the beneficiary guaranteed. It's up to you.
What would be kind of that regulatory or legislative ask, right? If you're to go to, the
So if
government.
it's regulatory side, then you go to the FTC and the Department of Justice, and you say it's time for these big behemoths to divest by vertical, right? So PBMs, you're out of the big insurance company. Providers, you're out of the big insurance companies. Everything else, IT services, you're out of the big insurance companies. If you're an insurance company, you have to take risk. You're an insurance company, and that's your business. That's it.
So complete, I won't say deregulation, but
Or
obviously
divestiture. Yeah.
yeah,
Yeah.
vertical integration has been, the path forward for years with acquisition, and the insurance company owns the entire stack now, right?
Right. And that allows them to game the system, right? So if your MLR is 85% and you have Medicare Advantage plans and you have ACA plans, well, you're paying more to your captive physicians and providers, right? So that hits against your medical loss ratio. And for your MA, it's amazing how the physicians that work for you will upcode, right? So that you get it ratioed up or whatever it's called, indexed up to show that your patients are sicker, so you get paid more. You know, everything is an arbitrage in the economics of healthcare. And that all starts with the scale of these big insurance companies.
And I think, scale is an important piece here, right? And I think that's part of, what Cost Plus brings to market, but especially Cost Plus Wellness, right? I mean, it's one of those things we serve, thousands of SMBs, which means not one of them, even if every one of their employees sat in the exact same zip code, right, could negotiate with these
A network.
facilities.
Yep.
But let's talk a little bit more about kind of what you're seeking to accomplish with that Cost Plus Wellness. I know there's been a number of questions, kind of even just in
Sure.
so far about it. Of, how are we assembling the masses there? How do people get access? Like, I think that's very
So right now, again, it's still in beta, not even beta alpha. So don't expect a lot if you go to costpluswellness.com. And the mission right now is just to negotiate contracts with providers of all kinds and then publish those contracts so that any employer can use them. It's not geared towards patients. It's not geared towards beneficiaries to do any comparisons. It's more to an employer, whether that self-insures. And particularly if you're in the Dallas-Fort Worth area, we've got more coverage there. But slowly but surely, we want to continue to add to build a network. We're not looking at this as a business. We're not offering TPA services. Maybe at some point, if we're able to put together the network and maintain all the contracts, we'll charge some amount per, a dollar per transaction or something minimal just to cover the cost. But I just want to fuck things up, right?
yeah.
That's what it comes down to, because it's so messed up right now. And going back to what David was saying, like these things are simple. Every insurance company puts together a network at some level. It's just that they all have their goals, right? Their economic goals, which typically don't align with the patient's economic goals, you know? And so we can disrupt that by putting together as many providers as we can. And if you're an independent physician and you're getting underpaid, you get to set your price, and like I said, if it can be, if you can schedule it, you can negotiate it. And nothing in there says there's no, exclusivities in any of the contracts. And so if there are 3 providers in your area, that are direct primary care, you choose which one, who's the best, who's the cheapest, whatever you decide, that's up to you. But what it's allowed, because I use it now for my companies and our members, and we still need a wraparound. So we use Aetna to get a wraparound network, and they've been fine with it. But with that, with our contracts, there's no deductible for our employees. We cover it, right? There's no even copay when they use Cost Plus or our network, because we want them all to want those doctors and send them there. And it's direct pay directly to the provider. So they're thrilled to death. There's no pre-auth, right? There's no paperwork. Maybe there'll be claims, because that's one of the only things we have to work out, because a lot of the TPAs that you'll work with need a claim to trigger the transaction. But for some employees, if you don't want that, you just pay it like it's 1955, right? You just pay the amount in cash or chickens, whatever you want to use, and your beneficiary is happy and everybody's happy.
I think that's one of those things, Mark, we often hear, as kind of there are a number of entrants into this higher performing network solution or narrow network, or, use whatever term you wish, is that, they seem to always come with exclusions, right? Or catches. And as a result, for the employer of choice who says, look, I want to offer a PPO network because my employees want to go wherever, however, talk to us maybe a little bit about how those contracts allow, an employer to build what they want, or are there exclusions and limitations?
Yeah, no, there's none, right? It's not even about building the network. These are all the contracts. And if you decide that this provider is somebody you want to work with, you take the contract, you sign it, you call them and say, we're ready to go. And that's it. There's no exclusions or anything. The exclusions are, it's not a complete network yet. There's a
Okay.
long way to go to cover nationally. But that's part of the reason I'm having these conversations, because we want more providers, doctors, mental health specialists, whatever it may be, MRI clinics or services, whatever it is, we want you to sign up.
And I think that's the other piece too, Mark, right? A lot of people talk about gaining access, but then it's the quote unquote, how good are the contracts, right? Access is one thing, price is another. And again, as you said, you can schedule it, you can negotiate.
Our contracts aren't great, right? Because
Okay.
we're small, right?
Yeah.
It's not like Cost Plus. Even with Cost Plus, when we started in 2022, we had 111 drugs. And they were like, okay, if you can do anything, we'll lower the price. And then over time, our prices have gone down significantly, and we pass on those savings. It'll be the same here. If we're able to generate enough volumes for the providers, those prices will go down. But they're still lower than than what your insurance company is going to negotiate, because it's more comparable to Medicare or cash price.
Sure. No, that makes a lot of sense.
It sounds like we need to pour a lot of gas on the fire, right? And get the
Yes.
momentum going. And it's
Yes.
interesting. We have a lot of distributors, if you will, on around the fire today.
Good.
Brokers, consultants, at the front line working with employers and whatnot. And there's a lot of questions coming through right in our Q&A as
Fire
to,
away. Yeah, fire
yeah,
away.
kind of where can brokers, help that are working with these employer clients? How can they take, a 5-gallon jug and throw it on your fire and build that momentum?
That's a great question. One, if you know any providers, because that's what brokers and consultants do, right? You try to connect them with the best doctors, the most cost effective. Send them to costpluswellness.com to sign up. That would be a big plus. Number two, for employers, whether they're level, whether they're regular businesses full, where the insurance company takes full risk. I still don't know all the terminology. I'm still learning. There's so many acronyms and nonsense, right? Or it's self-employed or self-insured. You know, Make sure that Cost Plus is part of their network. Make sure that you look at those contracts to see if there's a big employee base where we have a lot of providers under Cost Plus Wellness. You can bring in a wraparound network and use those contracts and complement and save them a lot of money, because it's as close as we could get to the equivalent of only using cash pay. And by the way, if and you guys know this as brokers and distributors and consultants, if you as the intermediary are willing to do the negotiations, you can get even better prices than what we negotiated. Because there are times when we have somebody who's on staff, all they do for our members is go negotiate. If you can schedule it, you can negotiate it. You were going to go to this doctor. What about this doctor? Do you care? Right? Do you want your own doctor? They're not part of what we have. We'll negotiate with them. If they don't negotiate, we'll still cover it, but you're going to have to pay a deductible, those types of things.
It's interesting, as we kind of think about the ways to pay for healthcare, people like hit a brick wall. They're like, the only way I can pay for this is with insurance, right? And I often laugh. I'm like, cash works.
Yeah.
Cash is king, man.
Doctors, yeah,
Right?
doctors love cash, right?
They like cash, patient assistance programs, right?
Right.
Foundational money, right? So it's always kind of comical, but sad at the same time because people get so wrapped around the concept
Well,
of,
there's because of fear, right? Insurance sales is about, a counter to fear. What if somebody's in an accident? What if the worst possible scenario happens? And that's what we're all afraid of. But fundamentally, if you can't afford your deductible, you're never going to get to that. And the insurance companies love that, because if you can't afford their deductible, there's nothing out of pocket to them. And so for all the consultants and brokers out there, that's your opportunity, to act as a fulcrum for all these different direct contracting and cash pays. And, I don't know the brokerage business well enough to know if, you have, you know, healthcare CFOs, if you will, that will negotiate for all your clients, or TPAs that'll do that for them, that are independent and transparent. But those are real opportunities, because right now, like before I got into this business, I had my broker, and it was always the same story. It was everybody else's healthcare costs are going up 10%. Everybody else's premiums going up 10%. You're only going up 6 because you're my boy. Then I learned how the industry works. We're no longer friends, right? He was making a killing and at my expense. So in any event, add cost plus drugs to your network, whatever PBM you use. If they won't let you, boom. If it's a bigger client that's spending tens of millions of dollars, particularly on pharmacy spend, then there are third-party auditors that'll work on a percentage of savings. I've never seen a company that had their PBM rebates audited that underpaid, right? They've only overpaid and gotten money back because all the PBMs know between fees, if in the contract, the PBM contract that you're signing for your client, there are any fees that are a percentage of the drug price, your client's getting ripped off. If there are specialty tiers that include generic drugs, your client's getting ripped off. And I understand you go out there and you sign them up for the PAP programs, you sign them up for copay maximizers, but even then, they don't count against their deductible. So if they don't get you, even if they might save money on your Eliquis, right, or your specialty drug, they're still going to get it some other way, right? And the insurance company still benefits by not having to come out of pocket. And oh, by the way, for those copay maximizers or even worse, accumulators, that PBM's taking 20, 30, 50% of it and giving the balance of it to the employer. So they're making money off their sickest employees. And the way I've really been able to freak CEOs out is, I ask them, what's your typical copay? I'm sorry, your typical deductible. And they're like $2,500 for most employees. Used to be $1,500. Even in the last 4 years, it's closer to $2,500 now. And I'm like, so let's just say you've got somebody that makes 40 grand a year, takes home 30, and now needs a $600 Eliquis, to use them as an example, right? Maybe you get a copay maximizer, but let's just pretend for this example you're not, right? That $600 out of pocket, 300 of that is the rebate. And chunk of that goes into the pocket of the PBM. And the other half or more goes to the employer. So effectively, during the deductible phase, the sickest employees are paying their money as a rebate to the employer. And then I just get quiet and let that sink in. What kind of article do you think that's going to make in the Wall Street Journal if somebody's really sick and can't afford it? What do you think is going to happen when an ERISA lawyer hears that you've got all these beneficiaries that are paying full retail price during their deductible phase because their maximizers ran out, and it didn't count towards their deductible, or they didn't even have a maximizer because it doesn't even work for everything, right? And so all of a sudden, you're going to be accused, because it's real, that your employees are writing you checks. Your sickest employees are effectively writing you checks via the manufacturer rebates. You don't want to be in that position. Like, well, how do I stop? What's going on? What do I do? I'm like, you don't work with that insurance company anymore, right? You have to figure out, starting with the PBM, you have to work with a pass-through PBM that's, it's going to show you all the rebates, not work with a rebate GPO, or if they do, pass that through to you so you know up front, and require that anything paid during the deductible phase goes against the deductible so that you can go out and work on cash pay with cost plus, or an MRI facility, whatever it may be, and that counts against your deductible, and you don't look like such a jerk.
That makes a lot of sense. Makes a lot of sense. We're the fire is starting to dwindle slightly here, so I want to leave a couple minutes for some Q&A, and there's some pretty interesting
Yeah, fire
questions.
away. Yeah, fire away.
From the folks sitting around.
And by the way, if anybody thinks I'm wrong, don't be afraid to tell me I'm wrong. That's how I learn. I like being told I'm wrong because that helps me make my argument stronger.
Fair enough. So one of the questions here from Brian Carter is, when will Cost Plus get to the point where they can replace the PBM completely?
Well, we're never going to do claims processing, right? So you can add us to your network today. And if you're working with a third-party TPA or working with a pass-through PBM, and by the way, if you go to business.costplusdrugs.com, you'll see a list of the pass-through PBMs that we work with. And they're all transparent as much as they can be. And they all include us, and not just for regular drugs, but our biosimilar. Like right now, here's a task for all the brokers out there. We sell a Stelara biosimilar for $420 every 3 months, I think they take it, right? So that's $1,280 a year versus whatever the biosim you think you can get for $3,000 or $4,000 versus 125 grand for brand Stellara. And it's available today. You can go to the pharmacy and tell them to buy it from us. You could tell, the PBM that you want that carve out and they're going to start buying it from us right away, right this minute. And for Humira, our biosimilar is called Usimry, and it's $484, but it's going to go down in price in the next couple of weeks.
No pharmacy discussion would be complete without the GLP-1 issue, right?
Yeah.
And I joke around, tomorrow's Wegovy Wednesday. So
That's a great line.
yeah. So the question here from Lynn Hailstone is, what are you doing or partnering with any of the drug companies in the GLP-1 space? What's your take on that?
So we will be partnering with both of them at some level. We're working on that. There's no guarantee it'll happen, but I think it will. But we're not going to get any special discounts, right? They're pretty much the prices are the same, and it's one price for the employer and one price for cash pay, right? And what I would tell you that's important is you want to carve out GLP-1s for two reasons. One, if cash price goes down, you can tell your employer, the sponsor, to make sure in their self-employed contracts with PBMs that anything paid at cash counts against the deductibles. So that's number one. And number two, you want to be able to have a direct line of communications for your biggest clients with the manufacturer. Because right now, with the biggest PBMs contracts, your sponsors are not allowed to talk to the manufacturers, which prevents them from putting together wellness programs. And so leading the way for them to talk to, Novo or Lilly and ask them what programs they have for adherence and, making sure it's best fit and all those things. That's a huge plus that you can bring to your clients.
Do you get into the compounding pieces and some of
We're
those?
able to do that, but we won't,
No.
right? Because that's all kinds of legal challenges. But you know, we can make them really, really cheap because we're all robotics driven. Oh my God, I don't even want to tell you what we can make it for. And we thought about it, but we don't want to be in legal battles. We want to be as squeaky clean as we can.
Ryan Ross has a question, kind of continuing on the prescription piece. Weird question. Does Cost Plus cover pet prescriptions or offer anything for?
No, but we're looking at it. The crazy part about pet prescriptions is the veterinarians actually make money on the prescriptions. So they don't want to send them in to a third party. So, even though it might be the same drug and they'll charge more than they do for the humans, they make the margin on it. So that's been the challenge.
Yeah, that makes sense. That makes sense. Although, the last time I took my dog, his name is Karsten. He's a 3-year-old German Shepherd. At least you know what you're going to pay before you pay it, right? They come out with an estimate and they're like,
Yep.
Karsten needs this, that, and the other, and your bill's going to be
You're
$800.
going to freak out what the number is, right, when it comes to the medications. But yeah, we're talking to a variety of different people about different options. But the reality is the veterinarians want to keep that margin.
Makes sense. Makes a lot of sense. Here's one, this again, kind of on the RX side from Annie. How about insulin? What are your thoughts around insulin?
Because we're primarily mail order, we have to cold ship, and so that keeps us from being really competitive. But if you go to teamcubancard.com, that's our list of affiliated independent pharmacies, and it includes Walgreens for that matter. But if you go into your local pharmacy, don't say you have insurance, and say I need Novolog, whatever insulin you use, and you need their best cash price. What does it cost? More often than not, then they'll be able to tell you what their best cash price, and it'll be cheaper than us because they get ongoing shipments in aggregate, so they don't have the cold chain shipping costs.
Here's one from Jake. Is there or will there be
From
a
State
focus?
Farm?
I think you know exactly that. Jake here is asking about, is there a focus on these $1 million cell and gene therapy treatments that we're starting
Yes.
to see?
Yes. So with our manufacturing capability, we can do biosimilars and we'll be able to do biologics down to the level of N equals 1. right? So there'll be certain things we'll be able to manufacture, but that's 2 years away. And in terms of the pricing for the multi-million-dollar deals, the hemophilia drugs and all that, that's tough right now. But what I would tell you, since most of the insurers want to laser that out, if you have a client with it, go to the manufacturer and see if you can negotiate a payment plan. More often than not, they'll allow that to happen.
This is an interesting one, and this kind of hits home for us here at Angle Health, because we are obviously an AI-driven type company. This is from Evan. I have to ask it, where do you see AI impacting drug prices, procurement over the next few years? Is there a place for that?
Yeah, of course. I mean, AI, there's going to be two types of companies in this world, those who are great at AI and those who went out of business. And so the only question is, where do you start to use it and how? And for my companies right now, we're starting from an agentic basis because even the smallest of companies, in particular, the smallest of companies, there's so many things that are manpower heavy in hours, where you need somebody to manually do all these reports or this or that, or look at things. And you don't want to do that because you'd rather have them be on more productive things that generate more savings or value. And so that's where we're, hiring young kids just to go through all of our stuff and find out what can we do agentically to reduce costs. And then in terms of the bigger stuff, we use AI in our factory with our robots to, track any abnormalities, to, track ranges of output of numbers that we need to know, everything. And so, yeah, AI is important. And the more efficient, we think that we are going to be in a position over the next 12 to 18 months where when you go to Cost Plus Drugs, you will see a red, white, and blue page that shows it was made in our factory in the United States of America, and that our prices, because of AI and robotics getting better and better, will be cheaper than what it will take to import for tablet-based and injectables.
It's amazing, again, like just the waste and inefficiencies of, the status quo system, of
Yeah,
trillions of
but that's the
dollars
opportunity. That's the
all
opportunity,
day.
right?
Yeah.
Right. But that's why you guys have Angle, right? And so, with us, it's more about, you know, on a macro basis, how do we just undermine or disrupt the capture from these biggest companies? And when you run with the elephants, there's the quick and the dead. And so we just have to be really, really quick, really, really nimble, and really adroit at using AI and using just common sense and being fair, so that we can be trusted. That's 90% of the battle right now. Can you be fair? Is your provider fair? And if you're fair, good things happen.
If you were to pick one kind of partied message for everybody on around the call today, what would that be?
Add cost plus drugs to every client network, of course. Um, but also realize that you need to have the CEO in your loop. In the small companies, that happens, but the bigger the client, the more need right now, because if you're dealing with HR, head of benefits, whatever it may be, CFO, they're under a ton of pressure to reduce costs, and you know that, right? And if you take the same normal approach as the salesperson walking in there, your back's going to be against the wall, which is why you're on this call. You're looking for alternatives. And I think keep up with cost plus wellness, in addition to Angle, obviously, but keep up with cost plus wellness, keep up with cost plus drugs, use our biosimilars, right? You can literally go to, if let's just say you can't get cost plus drugs into the network, but you can get an exclusion for biosimilars, or you don't care, you're going to tell your client to pay cash for it. You can go to teamcubancard.com and pick one of the pharmacies there, and we've got 17,000 of them now. And they can buy from our marketplace, Cost Plus Marketplace, they can buy our biosimilars right at our net price, right? Plus a little bit of markup for all that stuff. So, point being, if you have somebody in Salt Lake City or someone in Princeton, New Jersey, you find a local pharmacy, say, we want to buy Stargenza, which is their Stelara biosimilar, or Usimri, the Humira biosimilar. We're coming out with a Prolia one. Then would you please buy it from Cost Plus Marketplace, mark it up, some fair amount, because I want to save, I want to look like the hero and save my client $100,000 a year on Stelara, or $8,000 a month on Humira. And so that's the thing. And then finally, educate your employers that are addicted to rebates that it's your sickest employees that pay for the rebates. If nobody ever got sick and nobody ever needed a brand medication, no rebates would ever get paid, right? And so by definition, it's your sickest employees and your chronically ill employees that create the rebates that go back to the employer. And ask that employer, is it right for you to collect money? Now, the employer might say, well, we're buying down our premiums. That's nonsense, right? Because the if you do take 100% of your premiums and use it to 100% of your rebates and use them to buy down your premiums, the premiums benefit everybody equally, effectively by plan, but your sickest beneficiaries are the ones that have to pay that full deductible, that pay the rebates, right? So even though you might not keep that money as the rebates, your rebates, the sickest employees are subsidizing the premiums of the guys, of you, the CEO, and everybody else in the C-suite and everybody else in the company. And that's just not right that your sickest employees either put money in your account or help pay your salary or subsidize the premiums of everybody else in the company and start including you. Those are the things where you can open up the eyes of the CEO. Now, in terms of what comes next, it's going to be a process. You can try to direct contract as much as you can, and the more you can direct contract, whether it's using us, the better. Now that I think about it, with all the brokers and all the consultants and Angle, I would work together with the provider and get the providers to push to create your own network. Because if all the brokers had a network that they could use, you guys would make a shit ton more money because you would save everybody a shit ton more money. And they would call it the shit ton network because it saves everybody a shit ton of money. Right. And you can say, yeah, Cuban, they help them. No, but seriously, though, doesn't it make sense for the brokers, and your organizations and associations to put together something, some type of a network? You can start with Cost Plus Wellness, and any provider you get, you can add to Cost Plus Wellness. But the more you sign up, even if you're the ones organizing it, we'll add shittonnetwork.com to costpluswellness.com. There's a huge opportunity there.
Love it. Love it. Love it. Well, Mark, thank you so much for joining everybody around the campfire today. Challenging us to think, right, about things differently, bringing out things like fairness, and some of the strategies, also sharing, what you're doing, which is impactful, right? I mean,
We're trying.
this piece here will be a legacy, right? That you're building for the future of our country, in my opinion. And I think everybody on the call has to have some sort of personal mission, if you will, right? To be in this industry and help people, and change, what we leave for, future generations. Because
Well, if you guys, and if you guys get any ideas from, the people on the call, you guys know how to get a hold of me, send it to me. I've got a lot to learn. And so I'm here to learn. And you never know what little tidbit makes all the difference.
very
Yeah,
cool.
I would say to that point, right? Accessing again, as Marcus said, Cost Plus, right, is available on the Angle RX PBM program, both in network and via our ISP with Waltz Health. And in addition to that, Mark will be reaching out about Cost Plus Wellness as an opportunity to create turnkey level funded high performing networks where when and where available, as that grows, we'll grow with it.
Perfect.
Hey, we have a tradition here of giving away some stuff, and today, kind of our as our final kind of fall series around the fireside, we're going to pull three winners. So write down this email address, sales@anglehealth.com. And if I call your name, please send a note to sales@anglehealth.com. And we're going to be sending out some Angle Health Stanleys to those folks. So the first person
Guys,
that is
I gotta jump onto my next call while you guys do this. I wish I could stay for the Stanleys, but I gotta run. But I appreciate it. This was a blast. Thank you so much for having
Thank
me
you,
on.
Mark.
Mark, thank you so
Thank you
much.
guys.
So, first up, we have Brittany Phillips. Brittany Phillips, if you could send a note, you're one of the winners. Dennis Watkins. Dennis Watkins. And again, I'm just scrolling through here and picking random. How about Stephen Meyer. Stephen Meyer. So if y'all can send an email to sales@anglehealth.com, we'll get that going for you. I am going to share my screen again real quick here as we kind of wrap things up. All right, perfect. Hey, some other folks that are on the call today, Liz Wilson, Garrett Second, and Eddie Diarmas are our VPs in our various regions here. If you want to learn more about the Angle Health platform and how we're working with Mark and his organizations, drop Liz, Garrett, or Eddie a note. Again, if you send it to that sales@anglehealth.com, just specify where you are in the country, and we will respond appropriately as well. The last piece of the puzzle here is kind of looking forward. So keep an eye out for new and upcoming chats coming in next quarter. So we're going to have a winter series coming out here as well. Caleb, any parting thoughts for everybody on the call this afternoon?
No, we're excited about our fourth quarter here. We appreciate everyone who's been able to join us, who's bought into the Angle Health solution. And I think those that have joined here obviously are interested in disruption, all of the conversation with Mark, but also interested in providing access and ease of care, something we really pride ourselves on here at Angle. And again, it's just making things easy. Healthcare has become too complex, as many of you all know, and we're proud to ultimately offer, again, a more simple solution while still providing the access and care that members need. So thank you for everybody for their support. We're excited for our biggest fourth quarter yet, and more to follow on good and do things from Angle, including soon access to Cost Plus Wellness's network, as we'll be working on integrating that for 2026. So thank you all. David, thank you as always for your master of ceremonies, and we'll be in touch soon.
Have a great fourth quarter, everybody. Thanks again.
Thanks all.